The topic of presentations today is vaccination, particularly the coming COVID-19 vaccine, and the likely fortunes given the rising levels of hesitancy about vaccination in general and the COVID-19 vaccine specifically. We couldn't be meeting at a more opportune time. The winter second wave, or third, or fourth, or fifth, or however you want to call it, is already upon us. Pfizer has just announced that its vaccine demonstrated that it is 90% effective in preventing infection. And yet, in recent polls, roughly half of the respondents say that they are unlikely to seek vaccination for COVID-19. Within weeks, probably, the FDA will be faced with the decision whether to approve the vaccine under the emergency utilization. The agencies around the country will have to address head-on the problem of public mistrust, particularly caused by the rapid process of development and approval, but also due to other reasons. For these reasons, we asked our panelists, how do they envision the likely reception and impact of a COVID-19 vaccine? Simply, are we likely to see the same kind of mistrust of this vaccine as happened with the MMR vaccines and others? Is this mistrust really temporary and due to the political tug-of-war over the vaccine, or is it something more longer term, more fundamental, akin to other vaccines, and something that we will have to deal with in the future? We have assembled an esteemed group of experts today to address these questions, to put them in historical and sociological context, and also to address the practical and policy sides. They are in the order that they will present: Professor James Colgrove of Columbia's Mailman School of Public Health, Dr. Amanda Cohn of the CDC, Professor Rupali Limaye of Johns Hopkins, Professor Jennifer Reich of the University of Colorado, and Jane Zucker of New York City's Department of Health. Before I introduce our speakers, I'd like to acknowledge and thank the Mellon Foundation for its generous support for making this event and many others possible. I also would like to note that this is our last event this term, and we are planning to dedicate the next academic term to the theme of trust and mistrust in science and experts among New York City communities. Details will follow. One last housekeeping note. The audience can see that they have a Q&A button. They can use this Q&A button at any time and type their questions. Once all the speakers are finished, I will read those questions in the order that they were received or in the order that they have been upvoted, because the audience also have the opportunity to vote, upvote questions that they would like to be answered. And then those you may want to indicate indeed to whom you are addressing those questions, but the presenters, the panelists will have a chance, all of them, to weigh in. Okay, so our first speaker today is Professor James Colgrove. He is a professor of sociomedical sciences at the Mailman School of Public Health, and his research examines the relationship between individual rights and collective well-being and the social, political, and legal processes through which public health policies have been mediated in American history. Very relevant. His most recent book is Epidemic City: The Politics of Public Health in New York City, in 2011. Previously, he was also the author of State of Immunity: The Politics of Vaccination in 20th Century America. Please, James, the floor is yours.
Thank you very much, Gil. It's really a pleasure to be in conversation with such a distinguished group of panelists. I'd like to offer some perspective on mistrust of vaccination by situating this issue in a historical context and highlighting a few things that I think history suggests we should keep an eye on. Could I have the next slide, please? We are unquestionably in an era of heightened mistrust of vaccination and increased visibility for vaccine skeptics. This mistrust has often played out in recent years in the context of opposition to state laws requiring children to be vaccinated in order to attend school, as in this protest 5 years ago when the California state legislature eliminated the state's provision for non-medical exemptions. But mistrust of vaccination is not a new phenomenon. On the contrary, resistance or suspicion of vaccination, what today we group under the much broader rubric of vaccine hesitancy, is as old as vaccines themselves. The first anti-vaccination organizations were founded in the 19th century, and in many ways, their messages have remained remarkably consistent over time, expressing linked concerns about safety, bodily integrity, and government coercion. For example, you can find the phrase medical tyranny, which you see in the placard in the foreground there, in anti-vaccination pamphlets of 150 years ago. Of course, notions of freedom have always been central to our country's political culture, and attitudes towards vaccination have reflected that, especially in the case of mandatory vaccination, but not only. Even in the context of voluntary vaccination programs, vaccine use has often been framed as an issue of medical freedom. The prominence of vaccine skeptical messages in the public sphere has waxed and waned over the centuries, with vaccine critics being very prominent in some eras and largely invisible in others. In stark contrast to our current moment of vaccine mistrust, we can go back 65 years to what was arguably the most acclaimed vaccine launch of the 20th century, the licensing of the Salk polio vaccine. Next slide. The introduction of the polio vaccine represented a high watermark for vaccine trust and confidence. In 1954, 1.8 million children were enrolled in the vaccine trials. It was the largest medical experiment up to that time. And when the vaccine was shown to be safe and effective in the spring of 1955, it was an occasion for national rejoicing, and people eagerly sought to get the vaccine. So how do we account for this? Well, for one thing, polio was a highly feared disease because it primarily struck school-aged children, and in its paralytic form, it left some of its victims unable to walk. Just as significant, the post-World War II decades were the era of the miracle drug. This was a period that saw many pharmaceutical breakthroughs resulting in new life-enhancing medications, antibiotics, immune globulin, corticosteroids, treatments for TB and leukemia, many others. Physician scientists were cultural heroes during this era. Next slide. Jonas Salk, the developer of the polio vaccine, was widely hailed in the media, as in this cover story on Time magazine, the leading weekly news magazine, featuring this rather surreal image of hypodermic needles jabbing a set of leg braces that symbolized paralytic polio. Trust in the federal government was not really an issue in this episode because the federal government largely sat on the sidelines. The trial, the vaccine trial, was conducted by a well-known and respected charitable foundation. The Eisenhower administration was in fact widely criticized for its failure to plan for the rollout of the vaccine and to organize the distribution of it. In the months following the licensing, the distribution of the vaccine was quite chaotic, with uncertainty about who should have priority for receiving the initially limited stocks of the vaccine, how much, if anything, people would have to pay for it, and where they were going to receive it. Eisenhower's health secretary argued that federal involvement in vaccine distribution would be an opening wedge for socialized medicine. In the absence of federal guidance or assistance, states and localities led the way. Next slide, please. The New York City Health Department, the largest and most professionalized local health authority in the country, for example, undertook an extensive and effective array of activities to meet public demand, including things like mobile vans in medically underserved areas of the city. So the reception of the polio vaccine represented the apex of trust in medical science and acclaim for vaccination. So how did we get from there to here, from a historical moment when millions of people clamored for a newly licensed vaccine with little concern for potential unknown side effects, to where we are today. Well, one thing that happened was that in subsequent decades, there was a notable decline in public trust for powerful institutions and authorities across the board. Public opinion polling showed notable drops in the confidence people reported in many previously trusted institutions, including the federal government, the military, the church, and the medical profession. There were complex reasons behind these declines, including an unpopular war in Vietnam, the Watergate scandal that led to President Nixon's resignation, and the revelation of the Tuskegee syphilis study and other scandals involving the abuse of participants in biomedical research. Next slide, please. This decline in trust was the background for one of the most infamous debacles in the history of vaccination, the ill-fated swine flu vaccine campaign in 1976. After an Army cadet in New Jersey died of the flu in January of that year, viral culturing revealed that the strain was closely related to the one that had caused the worldwide flu pandemic of 1918. Alarmed officials at the CDC pressed ahead with a mass campaign to protect all Americans against a possible return of the deadly pandemic. The effort was plagued with problems from the outset, chief among them the fact that the medical and the public health community was divided about the need for the campaign. Many experts believed that the threat was not as imminent as the CDC feared, and that the plan was far too ambitious. There were concerns about liability for vaccine injuries, and Congress passed a bill authorizing the federal government to assume liability. Next slide. This was in the midst of a presidential campaign. President Gerald Ford was photographed getting his vaccination while his opponent, Jimmy Carter, declined to be vaccinated. The media coverage of the campaign was generally quite negative, as illustrated by the article in the previous slide. And public opinion polls indicated that the majority of respondents did not intend to get vaccinated. Towards the end of the year, it became apparent that the vaccine had a rare, serious side effect, Guillain-Barré syndrome, a rare neurological disorder. The CDC abruptly shut down the entire campaign around the end of the year, and the feared epidemic of swine flu never materialized. The episode was widely seen as a PR disaster for the agency, and the head of the CDC lost his job over it. The failure of the campaign both reflected and contributed to a loss of trust in the public health establishment, and it remains a cautionary tale about the potential downsides of rapid and aggressive public health action. Next slide. The other controversy I'll mention is one that I'm sure is familiar to many of you, and that's the fallout from the infamous Wakefield study in The Lancet in 1998, asserting a causal link between the MMR vaccine and autism. This is what you will find if you go to look up that paper in the Lancet archive. The paper was retracted 12 years later, after having been determined to be fraudulent, and Wakefield lost his license to practice medicine in the UK. But by that time, the toothpaste was out of the tube, and the false theory had become permanently embedded in the public consciousness. Next slide. We can attribute the spread of the theory in part to the explosive growth of the internet and social media in the early 2000s, which is arguably the most consequential historical trend of the last half century. If you Google vaccination today, you will probably come across some of these sites as potential sources of guidance. Social media companies have gotten some, I think, very well-deserved criticism for their role in spreading vaccine disinformation. Google did change its algorithm so that you are less likely to see the National Vaccine Information Center, whose logo you see there, which is actually a prominent anti-vaccination site. But trying to stem the tide of vaccine misinformation on the internet is like playing whack-a-mole. The transformation of the information environment and the emergence of the post-truth, post-fact era may well be the biggest challenge facing public health with respect to a COVID vaccine. Next slide. And by the way, as some of you probably know, Andrew Wakefield has since relocated to the United States, where he has gained the ear of some prominent supporters. So where does that leave us today? I'll conclude with a few reflections on what I think we can take away from these brief historical snapshots. First, effective public health efforts to promote and distribute a vaccine are necessary but not sufficient for achieving high uptake. Public health responses to a vaccine, public responses to a vaccine are always affected by social and political factors that are not fully under public health officials' control. And even if the messaging about a COVID vaccine is clear and consistent, and even if the rollout and distribution run smoothly, we may well see widespread refusal of the vaccine. Next slide. Anti-government rhetoric has become more salient in our civic culture since the ascendance of the Tea Party a decade ago. And in contrast to the widespread public fear of polio a half century ago, some people do not believe COVID to be a true threat, although of course that may be changing as we speak. Second, because resistance to vaccines has always been closely linked with concerns about coercion, any move to mandate a COVID vaccine as a way to achieve high uptake should be approached very cautiously. And here I'm not talking only about government mandates. Private institutions also have coercive powers, whether, for example, private colleges and universities like Columbia will require students residing in dorms to be vaccinated against COVID, the way many colleges require vaccination against meningitis and MMR, is a potential flashpoint for controversy. As we've seen in the opposition to masks, some people perceive even a strong recommendation to be coercive, even in the absence of any sanction for non-compliance. And lastly, and to perhaps end on a somewhat less downbeat note, I think it's important to remember that just as these protesters do not represent mainstream opinions about the use of face coverings, most opinion polls show large majorities of the public favoring mask wearing and even mask requirements. The vehement opposition to vaccination represented in my opening slide of the protesters in California represents only a tiny sliver of the general population, and really only a sliver of the broader landscape of vaccine hesitancy. What is termed vaccine hesitancy encompasses a broad range of beliefs and behaviors that includes people who reject all vaccines, but also those who may vaccinate selectively and those who follow CDC guidelines but feel uneasy doing so. And I know my fellow panelists will have more insights into that. Although the relatively small number of vehement opponents of vaccination will no doubt shape the public response to a COVID vaccine, there are much larger segments of the population who will be open to being persuaded. Thank you very much.
Thank you, James, for this very clear view into the past and sort of setting the terms for the discussions that will follow. Our next speaker is Dr. Amanda Cohn. She is a board certified in pediatrics. She's a fellow of the American Academy of Pediatrics. She joined the CDC in 2004, and now she is the executive secretary of the CDC's Advisory Committee on Immunization Practices and the acting chief medical officer for the National Center for Immunization and Respiratory Diseases, also a senior advisor on vaccination for the Office of the Director of the U.S. Centers for Disease Control and Prevention. So she has many hats and precious little time. So thank you, Amanda, for joining us and letting us know of the CDC's plans and thinking about this issue.
Great, thank you. And Dr. Colgrove set me up perfectly for this discussion, but I appreciate being invited to be here virtually today. I'm going to talk to you about a strategy to try to address the whole spectrum of vaccine hesitancy related to COVID-19 vaccines. Next slide. So what are some of the things getting in the way of vaccine confidence in the US? We know that we've seen a considerable decline in COVID-19 vaccine acceptability, as Dr. Colgrove just mentioned, over the last 4 months. When we do focus groups asking about what people's concerns are, people are concerned about side effects, efficacy, risk perception informs their considerations about vaccination, and potential costs. So we know that perceived safety, cost, and acceptability can all affect vaccine acceptance. But attributes that made COVID-19 vaccine more acceptable included if your healthcare provider said it was safe, if there are no additional costs to the individual, if it would help you get back to school or work, and if you could get it easily from a walk-in or drive-through clinic, pharmacy, or doctor's office. Next slide. So this slide illustrates Dr. Colgrove's discussion about there being actually very few people who will absolutely be on the spectrum of protesting and being vehemently against vaccines. We are seeing that most of the US population is somewhere in the middle, especially with COVID vaccines. The development of these vaccines has been very quick. And so there are real questions that people have. And when we do interviews about why or when people might want to get vaccinated, what we hear a lot of is, I'm going to wait and see. There's concerns that the clinical trials have not been robust enough or not the same as for for normal vaccine approvals. When in fact, the number of people who have been enrolled in these clinical studies is equal to or larger than most vaccine clinical studies. It's just been conducted in a very fast, at a very fast pace by enrolling very rapidly. Next slide. So this is a new pandemic. Everything has changed in the last year. We have new vaccine platforms. These vaccines are very different. It's not just another influenza vaccine, which is what H1N1 really was. And we need to focus this vaccine on adults, which really shifts our tactics about how to address vaccine hesitancy in the United States. Our prior strategies and tactics focused on childhood vaccination primarily, and Dr. Zucker, who's presenting later, had to deal with this for an entire year during the measles outbreak in New York City. But this is going to be very different than, and all of the tools that we learned from that experience will help inform this strategy. But we also know that many individuals will have concerns. And these concerns really are understandable and need to be addressed with empathy and transparency. I have concerns right now. I know that when I see the data, and I know that independent advisory groups are reviewing the data and will make decisions based on the safety and efficacy data, so my concerns will be addressed, but I have knowledge that those concerns will be addressed, and we need to explain that to everyone. Big difference in this outbreak, in this pandemic, is that we're seeing more concerns among healthcare providers, and this is a real risk for overall vaccine confidence. We know that healthcare providers are the most trusted source for health information, not only for their patients, but also for their family members. Healthcare providers, in all doctors, nurses, pharmacists, all types of healthcare providers touch almost everyone in some way through their circle, through their social setting circles. Finally, we do know that communities will have unique experiences informing COVID-19 vaccine perceptions, and engagement with community organizations and leaders will help us expand access to clear and accurate information on COVID-19 vaccines. Next slide. So this is the CDC, or National Strategy to Reinforce Confidence in COVID-19 Vaccines. And this has been developed by CDC, and we are developing tools and content to support this strategy, but this is not implementable by CDC. This requires an all of society approach to implementing in order to be successful. The biggest disaster would be if we put all of this effort into getting vaccines, safe and effective vaccines, into providers' offices and nobody was there to take it. So if we can't get vaccines in people's arms, this vaccine program will be a failure, really. So this is one of the most critical things we need to work on over the next couple of months. The first pillar of this strategy is to reinforce trust. The second strategy is to empower healthcare providers. And the third pillar is to engage communities and individuals. And I'll discuss this a little bit more in the next slide. Next slide. Great. So reinforcing trust is a really critical component of increasing confidence in the United States right now. When I listened to focus groups, people were really thoughtful. They're watching the news, they're hearing misinformation, they're also hearing from Dr. Fauci, and they're trying to connect all of these dots. And we need to help them get there. So we need to be communicating transparently about the process for approving, making recommendations for, and monitoring the safety of and distributing COVID-19 vaccines. We need to be communicating now about that, even though we don't have information on the safety and effectiveness. We need to be talking about what's going to happen when vaccine safety and effectiveness data are available for review. We need to provide regular updates on the benefits, safety and effectiveness, including updates from an independent vaccine safety monitoring group, which we are setting up as an ACIP sub-work group, who will report to ACIP and to the public about the vaccine safety data after implementation. And we need to proactively address and mitigate the spread and harm of misinformation via social media platforms, partners, and trusted messengers. And I would argue that we are all well aware of much of the misinformation that's out there, but when you really look at misinformation that is even harder to address, it's misinformation that's spreading at a very local and community level. There is a lot of misinformation in ethnic media and on local radio stations and in more local settings that may not all go viral all the time. And so this is a national problem, but also a very local problem. So some of the tools that we are working on to provide our partners and jurisdictions to help is web content, such as vaccine information for you and your family, explaining the recommendation process, an interactive vaccine rollout timeline webpage, which we're working on now, and a field guide to address and build resilience against COVID-19 vaccine misinformation. And this is really for people to implement at a community partner level. Next slide. The second pillar is to promote confidence among healthcare personnel in their decision to get vaccinated and to recommend vaccination to their patients. A healthcare provider will not recommend a vaccine to their patients that they're not willing to get themselves. So we need to be engaging health systems and healthcare personnel often and earlier to ensure a clear understanding of the vaccine development and approval process. And we need to think of healthcare providers not just as physicians, not just as nurses or pharmacists, but really everyone in the healthcare setting is a part of this. We know that home health aides, persons working in long-term care facilities, there's 21 million healthcare providers in the United States, and their backgrounds are actually very similar overall to the US population in terms of education, race and ethnicity, and obviously geographically. So a lot of the tools that we're developing for the public need to first be really focused in on healthcare providers. We need to ensure that healthcare systems and medical practices create a culture that is supportive of vaccine administration, including tools like safe guidance for safe COVID-19 vaccine administration. And importantly, we need to support empathetic vaccine conversations in healthcare encounters to confidently address vaccine-related questions and provide tailored vaccine information to patients. So we may not be initially distributing vaccine. You may not be going to your healthcare provider to get vaccinated in the early part of this rollout of vaccine. You may be going to your local health department. You may be going to a pharmacy. We do anticipate that eventually providers will also have vaccine. But regardless, we need healthcare providers to start now with patients and persons that they're seeing in the healthcare setting to reinforce and recommend vaccine when it's available. Simple products in this space include talking to patients about COVID-19. We're developing slide decks for healthcare personnel to use in their offices to talk to their whole practice, and answers to common questions about COVID vaccines, almost like a cheat sheet for healthcare providers to use when talking to patients. Next slide. The third pillar of this strategy, which is the one that is so important and challenging in this pandemic is to engage communities in a sustainable, equitable, and inclusive way, using two-way communication to listen and increasing collaboration and building trust in COVID-19 vaccine. When we have outbreaks of vaccine preventable diseases in pediatric age groups, often in tight-knit communities, the way that local health shifts the tide and increases vaccine coverage in that community is by talking to that community often and regularly and in person and having roundtable discussions and parlor meetings. And this is really hard to do now. We really need to engage community partners in this work, and we need to engage our atypical immunization partners, such as YMCA and NAACP and other organizations. We need to work with jurisdictions and national partners to collaborate with these communities and service delivery strategies. And we need to make sure that access in these communities to vaccine is equal in all communities. So we need to support community-based health clinics and make those places where people can come and get vaccinated. We need to get vaccine to people. I think of this very similar to the recent voting experience we had. If you can make, people have differences in opinions and passions about whether or not to vote, but certainly the easier it is to vote, the more people will go to vote. And this is very similar to vaccine as well. We need to get vaccines to people as close as possible in these communities. So some of the products we're working on are Vaccinate with Confidence, a rapid community assessment guide. We're also working on slides for communities to use in multiple formats and languages, different reading levels. Some people need some information, some people need a lot more. And so we want to provide our partners and jurisdictions with materials that they can use. Many of our state and local health departments have amazing materials already, but these health departments and partners are certainly have variable amounts of experience in this space. So we want to make sure that across the country, everyone has access to really good information. We also want to develop briefing materials for ethnic media roundtable events where we can make sure that the media can communicate accurate information about these vaccines. Next slides. So this is just reinforcing some of the work that we're doing right now. And we are rapidly trying to get these materials out, including web content, tailored materials to educate healthcare providers and the general public. But we're also reinforcing existing partnerships and trying to develop new partnerships with organizations that serve critical populations. A lot of really good work has been done in the testing space with local communities, and we're hoping to build off of some of that good work. But we really need all of our partners to amplify these messages and provide trusted information to groups. CDC providing this information is not always the best deliverer of information. People need to hear it from people they trust. Next slide. This just talks about how our goal is to incorporate Vaccinate with Confidence into all of our activities. So it's really to review anything we're providing in terms of provider education and materials about vaccines through this lens of Vaccinate with Confidence to make sure that we're supporting people's decision to get vaccinated. And next slide. So Vaccinate with Confidence is, it's not a large scale advertising campaign. You won't see this like up on billboards and things like that. This is really more of a grassroots approach going from, working at the national, state, and local and community level. It's a cohesive framework to support health departments, healthcare providers, immunization partners, and community partners and leaders to promote COVID vaccines. Will provide evidence-based content to amplify these messages to enable an individual to make the decision to vaccinate. And this is really to counter misinformation that we know will be really challenging to get past. And this is really critical to ensuring safe and effective COVID-19 vaccines can help control and reduce the impact of this pandemic. The news that was out of Pfizer this week is really good news. We have a lot to learn about these vaccines, and we need to be clear that we will do everything we can to keep learning and to keep sharing information with the public as rapidly as possible. Next slide. And I'll end here. This is our COVID vaccine web pages where you can see some of the materials, and this will be updated frequently over the next several weeks. So I'll end there. Thank you for having me.
Okay, I'm not sure that I can be seen. Oh, okay, sorry. Thank you, Amanda, for this very informative and a view into this very thoughtful program that is being developed at the CDC. Our next speaker is Rupali Limaye. She is the Associate Director for Behavioral Research at the Institute for Vaccine Safety at Johns Hopkins University, where she's also a faculty member at the Departments of International Health, Epidemiology, and Health Behavior and Society at the Bloomberg School of Public Health. She has long experience in working on global health, topics that include immunization, family planning, HIV/AIDS, maternal and child health, etc., over 15 years and in 20 different countries. Rupali, please, the floor is yours.
Thank you so much, Gil, and it's great to be here. I'm so pleased to be on such a panel with some great speakers. I'm going to talk very briefly about some of the work that we have been doing, particularly through a communication lens in terms of how to improve trust related to hesitancy. So next slide, please. Thank you. So one thing, we've got some great news this week. This was just updated on November 9th. So how close are we to a potential COVID-19 vaccine? So you can see as of November 9th, we've had 11 different candidates that have made it to phase 3 trials. We can go to the next slide. Several other speakers have already spoke about this, but the great news that came out on Monday, where Pfizer announced that their mRNA vaccine was more than 90% effective. One of the things that we assume are going to happen with regards to this vaccine is that the FDA will most likely try to use something called an emergency use authorization. And so essentially using a mechanism like this allows products and therapeutics to come to market at a more rapid type of a stage. But one thing I think this is important within the context of what we are speaking about with regards to trust, there has been some precedent of using this type of a mechanism before for not only convalescent plasma therapy from the Trump administration, but we have also seen this through the hydroxychloroquine and a few other things that have sort of, I think, undermined trust in the whole process. And so I just want to point that out here. If we can go to the next slide. So one thing that we have been studying with colleagues is how can we ensure that when we provide public health recommendations related to vaccines, really reflect the state of scientific knowledge. And I think in COVID particularly, we're having a major challenge grappling with trust because of a number of reasons. So first of all, because we're dealing with a novel virus, we don't know that much about it. We're learning something every day. The science is changing every day. But because we're really in a point of crisis, there's a lot of uncertainty. The other piece I think that's really challenging from a trust perspective is that we're also seeing that the available preventive measures that we have communicated through public health authorities have a limited effect. And what I mean by this is that we're recommending individuals to wear masks, to social distance, and yes, we're continuing to see high rates of not only individuals that are getting infected, but also individuals that are getting hospitalized. So there's a real challenge here when you're talking to the public and you're asking them to engage in these types of behaviors, yet they're still seeing friends, colleagues, et cetera, really being severely impacted by this pandemic. The other issue I think that has been a real challenge for us from a trust perspective is this idea that politicians, rather than scientific experts and vaccine scientists, are really the public face of crisis management. You know, some of the work that we have recently done to understand hesitancy related to potential COVID-19 vaccines, several individuals have brought up this idea that the administration's naming of the program called Operation Warp Speed doesn't necessarily connotate or convey a feeling of thoroughness and safety, et cetera. And so it started even with just the name and thinking about some of the nomenclature that has undermined trust. We can go to the next slide. So I want to look very quickly and look at where we are in terms of attitudes. So this was from a recent survey. I think this was done, I believe, in September. This was among about 2,000 Canadians, where Canadians were essentially asked, once a vaccine against COVID is available to the public, do you intend to get it? And about 49% said definitely, and you can see how it broke down. If we go to the next slide, and we look at how this has changed, and we move here now, not to the neighbors to the north, but the US itself, we can see how things have changed over time. So what you're seeing here is you're seeing a tracking of specific seminal events that have happened during this pandemic here in the United States. And then the lines are where the US adults were asked whether they would get a vaccine if one becomes available. So you can see when the pandemic started, and especially when COVID was considered an emergency in early March, we've actually seen a decrease in the number of people and the proportion of people that would be willing to accept a vaccine once it's available. And this is a major challenge for us. Next slide, please. Thank you. So if we switch more to a global setting, right, and we look sort of across a cross-sectional set of countries, similarly, when we ask individuals about their vaccine attitudes, we're getting this sense of, so the dark green represents those that would strongly agree in getting a vaccine if one was available, and then the dark red is strongly disagree, right? So we're seeing quite a bit of variance here, from all the way to, you know, total percentage of agreement from 54% all the way to 97% in China. So my point here is that we are definitely seeing that there's a lot of variance with regards to attitudes, not only here in the United States, not only in Canada, but even globally is what we're seeing, which really has our challenges sort of cut out for us, for those of us that are working on increasing demand for potential COVID vaccines. If we can go to the next slide. So the question really is, what's driving hesitancy during the COVID-19 context? I've been studying hesitancy for several years now, and I've looked at it mostly related to routine vaccination. And so this is sort of a new approach. And I think the arguments are slightly different and are slightly nuanced. So next slide, please. So in terms of the arguments that have underlined why hesitancy has shifted, one thing that we continue to hear, and I think Dr. Colgrove also spoke to this, is that we're hearing these comments a lot related to tyranny. So, you know, even when recommendations are coming out from public health authorities that are saying wear a mask, social distance, et cetera, individuals are really seeing these as a threat to tyranny as well as individualism. The other piece, as I mentioned before, is that we're starting to hear this more and more, that authorities that maybe study science and study vaccine science, they don't know best. And now science is unfortunately becoming more and more a voice in the room. And I think over the last 6 months, we have really experienced that with regards to a lot of the communication coming out of the White House specifically. The other two pieces I want to spend just a little bit of time on are misinformation as well as the polarization of attitudes. So if we can go to the next slide, great. So in 2018, dictionary.com actually decided that their word of the year was misinformation, and there is some nuance here. So for example, when people spread misinformation, that means that they usually believe the information that they're sharing. So I might see something on Facebook or some other social media platform, I then share it with my colleagues because I think it's true. Now, contrast this a little bit to disinformation, where disinformation is crafted and disseminated with the intent to actually mislead other individuals. And so one thing that we have heard, for example, if a political leader claims that COVID-19 is no worse than the flu, despite knowing otherwise, that would be considered disinformation. So if we can go to the next slide. So in terms of what we are dealing with, you know, from a global perspective, there has been so much misinformation and disinformation that is being spread by social networks and social media platforms, I should say, is that one myth and one rumor that was being spread so widely that the WHO had to come out with this ad. We had heard from a number of individuals that people thought that you could get the virus through 5G. And so the WHO actually had to respond to this. So countries could essentially use these collateral communication materials to make it very clear that viruses cannot travel on radio waves or mobile networks. So this is just one example of some of the rumors that I think a number of us have been facing in terms of trying to combat. If we can go to the next slide. And one question that I think that has come up a lot is, why are we seeing more misinformation and disinformation, particularly related to the COVID-19 context? And I say this a lot, social media has been great in a lot of different ways. It's allowed a number of individuals that don't have access to information to be able to gain access to information. It allows for this information exchange, breaking down this digital divide. However, there's no fact checking that occurs. And I think, all of us that use social media know that. So as I mentioned, you couple this with this idea of uncertainty. We're dealing within a pandemic with a novel virus that we're learning about every day. And that sort of leads to people to, from a psychology perspective, to try to find answers where they can find them. And that's where really this misinformation is starting to really shine, I would say. This misinformation that is not only rooted in anti-science, but also in supposed vested interests. And the figure here on the right was a study that was done in April by the University of Oxford, and where they were looking at, I think, a little over 225 different pieces of information that were not correct on social media, and how many of them were reconfigured, fabricated, or satire. So they were trying to essentially categorize what were the types of misinformation that were occurring, that were particularly starting during the COVID pandemic. We can go to the next slide. Great. The other piece that we're really struggling with here is, besides misinformation, we're also seeing this polarization of views, which is really undermining trust in public health. So what I'm showing you here is, you can look at a number of Facebook clusters, so different social networks, and the red indicate connections that are anti-vaxxers, people that tend to hold attitudes that are more towards the continuum of not believing or not supporting vaccines. We then have those that are blue, and those are pro-vaccination, and then the undecided ones that are green. And what we are finding is that, one, there is a very, very stark polarization between these types of attitudes. And this has been growing over the last 20 to 30 years or so. The other piece that we're seeing is, when you think about innovation and the way that people garner and obtain new information, is innovation only happens when there are bridges between networks. But unfortunately, what we're finding, particularly within this pandemic, is that they are becoming more polarized. Now, this isn't only from, I think, a political ideology perspective. This is happening sort of across a number of factors. And so if we go into the next slide, I think we can learn a lot from some of the political scientists that have studied this work, is that we're really talking about echo chambers now. So parents might hear information, and the example I have here is related to the flu, but it also applies to the COVID context, is that parents hear information that it reinforces their own decisions. So when we think about networks, and when we think about who parents might listen to in terms of opinion leaders within their networks, it's usually going to be people that align with them with regards to their own vaccine attitudes. And so what we're really seeing is confirmation bias, and we're not necessarily seeing innovation of ideas and activities that would allow for new information, i.e. maybe a vaccine is good for you, among a group that might be more anti-vaccine with regards to their attitudes. So if we can go to the next slide. So we have done some work really focusing on how we can communicate to increase trust. And there's a couple of pieces that I have written here that we have learned. One thing, I think it's a natural phenomenon when you hear someone say something that's incorrect, you want to correct their misperceptions. And we hear this a lot, especially when we talk to parents and we talk to parents that are thinking about vaccinating their children, for example. Our instinct is to say, that's actually not right. But we have found really that this can lead to something called a backfire effect, or a boomerang effect. And so it's really important to not correct misperceptions, but instead to really focus on the disease. So when you hear someone say something that might not be true related to COVID-19, the vaccine or transmission or anything, the best thing to do is to move on and talk about severity and susceptibility of the disease. And the other piece that we've tried to spend some time on is using something called behavioral economics and trying to think about some nudging. So some individuals, for example, thinking about how we can get people to see vaccination as the default. And so that includes shifting the conversation just slightly in terms of how a provider counsels a patient. So instead of saying something like, your son is due for their measles vaccine, would you like to get it? It's slightly shifting that dialogue, and instead saying, your son is due, I'm getting the vaccine ready. So it's making vaccine more of the norm instead of giving individuals more and more of a choice. The other piece that we have tried to think about, and I really appreciated Dr. Cohn's earlier comments about empathy, as a parent myself of two small children, I also have questions. And I think a lot of the communication that has been focused on how do we increase vaccine acceptance has really looked at really focusing on vaccine acceptance without thinking about empathy and thinking about where parents are coming from. Parents have concerns and they should have concerns, right? They want to do what is best for their child. And so unless we can essentially restructure our conversation through empathy, we won't be able to build trust. So we did this, and we had a book, a number of colleagues that are I think people probably know in this space. A book was published about 2 years ago where we focus on this, and we have a number of talking points so that we can make sure that we can build a trustful relationship. So a clinician can build a trustful relationship with a potential parent, for example. We can go to the next slide. So again, what are some other tips of how practitioners can communicate to patients? And so as I just mentioned, really important, trust is number one, how to build, maintain, and restore trust. The other piece that we have learned, particularly related to this pandemic, is how to announce early. I work on the Baltimore COVID-19 response on behalf of Johns Hopkins, as well as a number of other entities. And one thing that we have tried really hard to do with our press briefings with the mayor is really focus on saying, this is what we know today, right? Even if it's, I'm not sure what we're going to do next. I don't know if schools are going to go back into session, but just announcing early. So having that transparency, which is my third point, is making sure that if you don't know something, being able to say, I don't know. We are trying to figure this out. We are trying to listen to the science. We're trying to listen to the evidence. And I think the other piece that really goes in line with regards to this building trust through empathy is this idea of listening. So really ensuring that we understand public risk perceptions as well as views and concerns, and not dismissing them, making sure that we are trying to meet people where they are, because they're also in a place where they are dealing with uncertainty and they're just looking for answers because it's part of human nature. So I think that's it on my end. I think I have one more slide after this, which I think is just my contact information. Yeah, so thank you so much. It's been great to be here.
Thank you, Rupali, for this really thought-provoking talk. It made me think of a lot of possible ways in which we could try to think about how to generate trust. Maybe they will come up in the Q&A. Our next speaker is Jennifer Reich. She is a professor of sociology at the University of Colorado. In 2016, she published a book called Calling the Shots, Why Parents Reject Vaccines. I teach this book in my courses. I think James teaches this book. I think many other people have turned to this book in the last couple of years as an incredible source of information and insights about this very question that we are dealing with here. Jennifer has done interviews with parents, with doctors, probing not just how many people are for or against, but really the reasoning and the concerns that are behind people who are vaccine hesitant. Okay, Jennifer, please.
Great, thank you so much. And I'm so happy to be here. I'm honored to be a part of this panel with some of my favorite researchers in the country, and also, I guess, to represent the Western half of the United States here. Go ahead, Erin, if you go to the next slide. So it's worth noting that when we started early in COVID, these memes started showing up everywhere very early on, and they were all very similar, which is to say that there was this kind of condescending reference to what infectious disease looks like without a vaccine. And they all boil down to the same kind of thing, which was like something like, how do you like the demo version of a world with no vaccines? And this seemed really compelling. There was a certain kind of virtue signaling, like, look, we all love vaccines and this is what you wanted, anti-vaxxers. But it was really the wrong message, and it didn't do very much for moving us forward. Next slide. So I started studying vaccine refusal more than a decade ago. And part of what I became really interested in was how we could have perceptions that are so far apart, that we could have generations of people who saw vaccines as a miracle, as a life-saving technology. At the same time, we saw increasing claims that this was part of a global conspiracy, that this was led by cultural elites to harm children around the world, and that this was in fact a kind of danger. And in thinking about how do we make sense of this distance and the ways that I've been thinking about it, what I thought I would do today is say a little bit about what I've learned about how parents come to reject vaccines, and then what we might learn about that would inform our conversations moving forward on a possible vaccine against SARS-CoV-2, the virus that causes the COVID-19 pandemic. And it's worth saying, I keep saying possible because although we have some good signals, we don't yet have a licensed vaccine. And I think that's really important to keep in mind. And I'll just confess that part of my interest in this is that I think there's a real possibility that a badly handled rollout of a vaccine might further diminish consensus that we have about all vaccines, which would be damaging in wholly new ways to public health. Next slide. And this is just a quick reminder that even today, while we are all living this in real time in a way that many have pointed out we haven't seen since the polio epidemic, we are also finding different signals of what this moment means. Next slide. So one of the things that's been really informative in my work is to think about what are the cultural themes and ideologies that inform how parents make vaccine decisions. And what I'm going to suggest to you today is that we have sort of two overarching problems that we've really doubled down on in thinking about public health. So one is when we think about the culture of parenting, we've increasingly defined good parents, and particularly good mothers, as people who make informed choices. And we've defined parenting as a process of consumer decisions for individual children. It is no longer simply just send your child to the neighborhood school. In fact, you should now do copious amounts of research on every school in the district. You should have consultants helping your children with applications. And the goal is to find the right fit for your child and not necessarily that your child fits into the community. We have similar ways of thinking about food, nutrition, breastfeeding, soccer teams, tutoring, and other opportunities. And so right now, the vocabulary of parental choice is it's not just ubiquitous, but it's actually become synonymous with what we define as good parents. Good parents are people who ask questions and make choices that feel customized and personal to their own children. Next slide. We've also done something really similarly around public health. Increasingly, public health has become not a community level or environmental intervention, but a series of messages about personal behaviors. So we increasingly ask people to track their calories, track their steps, eat a rainbow a day. And we also assume that when people become ill, it's usually something they did or failed to do. So we've accepted a kind of logic that health is personally controllable, that disease risk can be mitigated through hard work. And the challenge with this, of course, is that this is scientifically untrue, that most of disease lies beyond individual control, that we have genetics and environmental factors and bad luck that lead to diseases, and that you cannot entirely control disease risk. Nonetheless, this has become a really persuasive way of thinking about health and also disease avoidance. Next slide. When we talk about the ways we've communicated prevention for the COVID-19 pandemic thus far, we've really honed in on personal and individual behaviors. Now, when we look at these kinds of lists, things like avoid individual contact, stay home if you're sick, cover your nose and mouth, wash your hands, wear masks, avoid touching things, right? We are talking about individual behaviors. And some of those individual behaviors are in fact intended to support the health of the person making those behavioral changes, but some of them are actually intended for other people. And this is a nice reminder that we can't entirely personally control everything, and that indeed some of these individual behaviors are really powerful, but they alone don't work. Next slide. And one of the ways we see this is that we get news of super spreader events. And what we see quickly is that no matter how hard individuals work, they cannot entirely control diseases. So we saw examples this summer, for example, of a wedding in which the people who became infected hadn't actually attended the wedding. We see people who show up at choir practice who might do a great job of washing their hands and still become infected at what we are now calling super spreader events. And we can see the ways that no matter how hard we work individually, we can manage some risk, but we can't entirely control disease entirely, which then brings us back to the vaccine. Next slide. So what we can talk about from here is this question about, do you want a COVID vaccine? Or said differently, which is the way the question has been asked, do you want a non-specific but hopefully free vaccine? Next slide. So as my colleagues have already mentioned, what we've seen over time is declining enthusiasm for a vaccine. And so in this, this diagram from the Pew Research Center, what you see is that when this question was asked in May, as a hypothetical, do you want a vaccine? What you see is that between May and September, the percentage of people who said they would definitely get it has declined significantly. And when you break it down from political party, you also see significant declines amongst people who were the most enthusiastic initially, which were Democratic or Democratic-leaning respondents who have had the largest drop. And this tells us that over time, we've had declining enthusiasm, and also something has happened around our willingness to do this. Now, the initial promise of a vaccine, to be fair, is that when it was offered as a hypothetical, what we all heard was that we could get a magic bullet and that would allow us to return to life as usual. We could go back to stadiums and concerts, we could go to grocery stores and movie theaters, and we could trust that going out and participating in civic society would happen without risk, and would accept that we wouldn't have to work so hard personally to control risk because we would all be participating in something that would control risk for each other. And either optimism about that promise or trust in that promise is clearly declining. Next slide. What's not in that question from the survey is some of the possible challenges that we're starting to understand about the reality of what actually a COVID vaccine might look like. So some of these challenges will depend on which of the 11 or 150 candidates for vaccine, depending on when you start counting, make it to market, and which pass muster at the CDC level to be shown to be both safe and effective. But some of the challenges we may encounter in the near future if we do get a vaccine is that some of these vaccines are going to be 2-dose series that have to be taken approximately a month apart. If there's more than one vaccine on the market, we're not entirely sure how you'll know which vaccine to take, whether the card that you'll be issued will be enough to make sure you get the right one, whether the right one will be in stock. We know that given that a couple of the vaccines at least have to be stored at super cold temperatures, something like -20 to -90 degrees Celsius, we know that these will not be kept easily in your doctor's offices. And therefore you'll probably have to travel. And that raises new questions. How far would you be willing to travel? Although currently Pfizer's press release, which notably is not a peer-reviewed scientific publication, indicated that there are no safety concerns for the vaccine, what we do know from some of the reports about clinical trial participants is many described what they called a hangover effect after the second dose. So more than half said that after receiving COVID vaccines, they reported fevers, headaches, muscle aches, or injection site reactions, which could be pain or swelling. And so we have to ask real questions about, is that enough hassle that people are willing to handle it to move forward? And then one of the overarching questions, and I think one of the largest silences we have right now, is we have no idea how long people will be protected. We don't know if this will be a seasonal vaccine, an annual vaccine, or if we might get lower immunization coverage. And so while 90% effectiveness has been reported as similar to the measles vaccine, which is around 97% effective, one of the most important differences we have to understand is while you get 97% effectiveness for a very long time with the measles vaccine, that actually might not be true for this vaccine. This vaccine actually might end up looking more like a flu vaccine than a measles vaccine. And that doesn't make it not an important tool, but it does mean we have to understand exactly what that means. So what everyone's going to be looking at as they make decisions about whether or not they want this vaccine is how much risk will they face in getting a vaccine and how much benefit will they derive? And all of us are engaged in this question of risk and benefit analysis. Next slide. So some of the ways we can make sense is to think about how much are these hassles affecting people's willingness to get the vaccine. So when Pew asked additional questions, like if you have to pay out of pocket, what we find is that amongst those who are planning on getting the vaccine, who said that they would probably or definitely get the vaccine, the percentage who said that it would make them less likely to get the vaccine, either a lot or a little, depended on exactly these factors. Was there going to be a cost associated? Will they experience side effects? And then how effective is it? And will you need to get it every year? And each of these factors is affecting people's calculations of whether this vaccine is worth it to them. Next slide. So will people want this vaccine? Go ahead and move forward, Erin. The answer is going to be maybe. And it's going to depend on how a vaccine is relevant to personal goals. When we talk about the ways we've supported this vocabulary of individualism, vaccines being a technology for personal health promotion or optimization, and when we talk about the ways people calculate risk and benefit in their lives, what we know is that this vaccine is going to have to feel personally and individually relevant to individual and personal goals. And those might take all kinds of forms. They're not going to be one thing. So this might be the ability to visit your grandparents. This might be the right to work. This could be wanting to avoid long-term health consequences that are not just survival from the virus, but maybe long-term pulmonary or circulatory challenges that might follow. It might be access to education. It might be a range of kinds of factors that people are personally motivated by. And that motivation will help them decide, are they willing to absorb that post-vaccine hangover potentially? Are they willing to have some calculatable risk that might be lower than the risk of disease? Now, because this is a serious disease and a serious illness, generally we accept that there's a little bit more tolerable risk because the consequences are so severe. But vaccines are different than other pharmaceutical products in that we give them to healthy people. And so our calculations of risk have to remember that we are introducing a new risk to substitute for a different risk. And that calculation of risk and benefit should be very clear. Next slide. What we want to know as consumers is that this vaccine has followed the same rigorous process of testing and evaluation that all of our other vaccines undergo. And very few people really understand the back end process after the clinical trials, which I think are really important. So if you look at the last three colors, the sort of blues to the purples, what you'll see is that there are multiple levels of reviews between the CDC review panels that look at the safety and efficacy data before making decisions about licensing, but also thinking about the way that that's the FDA, and then thinking about the ACIP as a subcommittee of the CDC, which is scientific experts that evaluate who should get a vaccine, how it should be given, in what doses, in what combinations with other vaccines, and even if there are particular people who are not good candidates for it. And these processes are robust. Their meetings are public. They are experts in the field who are outside of government, who are evaluating information, who do not work for pharmaceutical companies. And those systems have been very good. What's also really important to know that few people understand is that we have pretty great systems for post-license market monitoring. So we know that there are multiple systems in place to look for things like upticks in emergency room visits following immunization that could signal an adverse reaction. We have voluntary reporting systems too. We have multiple systems between the CDC and FDA and then individual monitors to think about the different kinds of ways health data can inform the process of monitoring safety over time. And we have good examples in history of the ability to find minute risk because of these monitoring systems. I found in the course of my research that few people know about these systems, and these systems are really good. And what we would all want to know is that a vaccine that has been developed so quickly under unusual political pressure, probably not seen ever, or at least not since the swine flu vaccine that Dr. Colgrove just spoke about, that we would want to know it's being handled in the exact same rigorous ways. Next slide. So it mentioned some of these existing processes, and if you're interested in them, things like the CDC vaccine safety data link, the FDA Sentinel system, and then the voluntary reporting systems are really powerful in thinking about the different ways this could go. Next slide. And the last overarching piece that some of my colleagues have already spoken about is there's going to be concern about how this vaccine is rolled out and who is required to take it and under what conditions. We are unlikely to see a government mandate. We have no governmentally mandated adult vaccines outside of workforces. So we do have state requirements across the country for healthcare workers or medical students to receive things like influenza vaccine. Only about 16% of childcare providers are required to get a flu vaccine each year. So we have very few vaccine requirements for adults and really no great systems for tracking it. So we're really unlikely to see that. That doesn't replace the fact that in this particular vaccine, we've seen an unusual role for the military to be in charge of distribution, which has complicated optics in thinking about the role of government. Similarly, we know that this may be enforced at the private sector level. So in the same way that workforces are often the site of enforcement of things like influenza vaccines, we can imagine hypothetically that there'll be QR codes to get into stadiums someday. We could imagine cynically that we might see universities requiring a range of new vaccines, including this one, to be as a condition of education. And while we could say these are market solutions to complicated problems, we have to remember the private sector is also really ill-equipped to handle things like religious exemptions. They're ill-equipped to understand medical vulnerabilities that might undermine or interfere with people's ability to become immunized. And so we have to think about these both in terms of medical privacy and also community responsibility. Next slide. And I'm going to stop there and say that I think we have a lot of sources of optimism and also some cautionary tales, and that there's going to be important ways that we work together as we move forward. Thank you so much.
Thank you, Jennifer, for a fascinating talk and ending on a positive note. We definitely need it. Our last speaker is Jane Zucker of New York City Department of Health. Jane started her career at the CDC in 1990 with the Epidemic Intelligence Service, working in the malaria branch. She has also worked on Ebola in Sierra Leone during the Ebola epidemic. But since 2005, she has been Assistant Commissioner for the Bureau of Immunization and New York City Department of Health and Mental Hygiene. And in that role, she's responsible for policy development and program management of the New York City Immunization Program. And so we will end with the view from New York City as New York City prepares for the new vaccine. Jane, please.
So thank you, Gil, and also to my panelists. It's really my pleasure to be part of this afternoon's discussion. And I'll be providing a more a local health department perspective, really focusing on what the health department, how we've approached vaccine hesitancy in past outbreaks, and with other programs to promote vaccination. So next slide, please. So I will sort of touch on the measles outbreak in 2018-19, which Dr. Cohn had mentioned, our current experience with flu vaccination, and what the lessons learned are as we prepare for the availability of a COVID-19 vaccine. Next. So this slide, if vaccines are so good, why do we hear only bad stuff? So I wanted to start with this slide, which I used in a presentation last week for an infectious disease epidemiology course for one of the local schools of public health. And in that talk, I go through sort of the impact of vaccines really over for more than a century, and look at what pre-vaccine morbidity and mortality was, and how many of these diseases have sort of been brought under control, in some cases eradicated, for example, smallpox, and just how valuable vaccines have been in public health. I talk about polio eradication and measles, also human papillomavirus. And then with this slide, I transition to talk about addressing vaccine hesitancy and the challenges that we have in vaccine programs. And one of the topics that is discussed is the Wakefield study, which was referenced earlier. So I thought that this was a very appropriate introduction to my presentation today. I'm just highlight again, we've mentioned sort of the controversy issues, what's in the sort of media in terms of celebrities who may be promoting anti-vaccination messages. I think what we do in preventive health is not glamorous. We can't measure if there are no cases, that's good. But again, there's no way, you can't congratulate yourself sometimes for that there's no disease. You often lose funding. If something is under control, then we don't need further investment. And that to a certain extent, we are victims of our own success, and that people no longer fear diseases that they don't see. And there certainly is less tolerance around potential vaccine adverse reactions. So with that, I'll start with the next slide and move into the measles outbreak. And so this, we had 649 cases in New York City. This was the largest measles outbreak since the early 90s, and was the outbreak started when an unvaccinated child came back from Israel, where there had been a large outbreak going on. So this outbreak lasted 10 months and was quite a challenging outbreak to bring under control. It did affect many parts of New York City, but predominantly was centered in the Orthodox Jewish neighborhoods of Borough Park, which is shown in the orange, and then 3/4 of the cases were in Williamsburg. Next. So what's important for this discussion is that 43% of our cases were 1 to 4 years of age, and the median age of all our cases was 3 years. So this really was an outbreak among unvaccinated younger children. And this is, again, we see hesitancy in this community where children are often not vaccinated until they need to be, and that's because of school and daycare immunization requirements. So really, there was this large sort of buildup of susceptible sort of younger population. Next. And of course, as in most outbreaks, most of our cases were unvaccinated, 73%. Just to note that there were another 15% who had an unknown vaccination history. Most of those were adults, which is really no surprise. But that large chunk of preventable cases, these are persons who were 12 months of age and older, accounted for a lot of our cases. And had people been vaccinated on time, this outbreak never would have happened. And again, you can see this sort of large number of cases, again, in that 1 to 4 year age group, which had not been vaccinated. Next. So I think the appropriate sort of lessons, as we're going to talk about COVID vaccine later, the department undertook a number of different, really many different interventions and strategies to sort of bring the outbreak to an end and interrupt transmission. But I think what were really especially important was the community engagement. So there were numerous meetings with local religious and community leaders, as well as elected officials. We collaborated with key community partners, and it really was quite exciting because some new partners did emerge through the outbreak. And one example of one of these partners was the Jewish Orthodox Women's Medical Association, which had actually come to the department wanting to be able to provide MMR vaccine sort of almost on demand, but in the person's home, to address some of the concerns that community members had with bringing their child into the doctor's office for vaccination. So there wasn't a huge uptake for that particular program, but what it actually morphed into was something really important, because they did run a hotline where parents can call to schedule immunization. And this ended up being a very important source of accurate information about vaccination and about the measles outbreak and MMR, or measles, mumps, rubella vaccination in particular. And then there were other partners, and the fact that these partners were from the affected community, they were more effective voices than the health department was. And that was actually something that was mentioned by Dr. Cohn earlier. So we also sent letters in terms of getting accurate information to parents, and letters were sent through schools. We also sent letters to households where there were unvaccinated children. Next. I think also there was a lot of effort in media and community education. And I think as we roll out COVID vaccine, it's really going to be tailoring our messages for really the many, the diverse communities within New York City. So in terms of the measles outbreak, right, all of our media had to be in English and also in Yiddish. A lot of it had to be in print. Some of the social media may not be used as much by some members of the community. We had co-branded ads. Again, that's where the trust comes in, that we had trusted community organizations who co-branded our media, our newspaper ads with us. And something like WhatsApp ended up being very important, where we may not often use that. The health department may have Facebook ads, for example, but again, Facebook would not have been a particularly good route to access this community. Some of the materials we distributed, and two of them are mentioned here, Tim Gazette booklet, that was actually developed by the Hudson Valley Health Coalition. And they were community-based organizations, medical providers who represented the Orthodox community in upstate New York. So they developed materials specifically to address concerns of their community. And Slice of Pie was also like that. That was developed by the Vaccine Task Force, and they call themselves EMIS, and it's Evaluating Medicine with Evidence and Sensitivity Initiative. And that, I think the sensitivity and the work that they did was particularly important, and that sort of resonates with what we just heard about the importance of empathy when we're talking to parents about vaccination. So we were able to help facilitate distribution of these materials. to over 29,000 households in the affected zip codes. Next. So this is a picture of a slice of pie, and I think what's really great, this is the MMR edition, and it spoke to a lot of vaccine misinformation, which was being disseminated by a group called PEACH, and they stand for Parents Educating and Advocating for Child Health. And of course, on the surface, that sounds like, well, that should be good. But in fact, when you read their materials, there was a lot of, it was all vaccine misinformation, information taken out of context. And so the Vaccine Task Force developed this document specifically to address all these falsehoods that were being propagated by PEACH, and also to do it in a culturally sensitive way that spoke to, again, the community affected by the outbreak. And I will also say that the PEACH group actually deliberately targeted these communities for anti-vax material. So it wasn't sort of accidental the way in terms of how this information was disseminated. Next. This graph is showing measles, mumps, rubella, MMR vaccine uptake in children 12 to 59 months of age in Williamsburg. Again, this was the age group and the neighborhood that was most affected by the outbreak. And we were able to track this over time in terms of number of doses which were administered. And the solid line shows vaccine administered in 2018-19 compared to the previous year. And I wanted to highlight what happened when the outbreak was declared. So without any intervention, there was a large increase in vaccination. And I think that speaks to some of what we've been talking about, is that there was this perceived risk of measles now and recognition of the severity of measles. And so parents did take their children to get vaccinated, again, when there was this heightened risk. Whereas I think normally, I would often hear that, well, there's no measles, there's not an outbreak, I'm gonna wait. I'll wait till my child's going to school. But again, the occurrence of this outbreak really did spur parents to bring in their children for vaccination. Next. So I'm going to turn to flu vaccination, and this shows, this is the graph showing flu vaccine coverage among adults in New York City, and this is from the 2019 Community Health Survey that we do. And about half of adults get a flu vaccine every year, and we've made sort of slow but steady progress. The graph shows the different age groups, and I'll just highlight the top line, which is in gray, which is for 65 and older, where we've made significant strides, and coverage was 68%, and we're getting close to the national goal of 70%. And we're particularly worried about this age group because 85% of deaths in New York City are among the 65 and older population. Next. So this data is showing the coverage data, but now stratified by race and ethnicity. And this highlights the challenges that the health department has had, that we do see significant race and ethnic disparities, with Black, non-Hispanic New Yorkers having significantly lower flu vaccine coverage compared to other groups within New York City. Next. But there is good news. So the health department's really done a lot, and put in a lot of effort to trying to reduce this disparity. And this graph shows coverage among adults 65 and older, also stratified by race and ethnicity. It's comparing the results of the 2019 Community Health Survey in orange to the results of the 2018 survey in blue. And what is really important is that coverage among Black, non-Hispanic New Yorkers 65 and older significantly increased from 50% to 63%. And in fact, across all the race and ethnic groups represented on this slide, there is now, for again this year, no racial and ethnic differences in coverage. So I think it is, possible, to identify strategies to really address, both disparities and equity in providing vaccines. Next. I think in terms of flu vaccination this year, we've seen really unprecedented increases in flu vaccination, and this is from the press release a little over, I guess about 2 weeks ago now, showing that our early data shows a 37% increase in vaccination for adults and a 27% increase in children. Next. Right, so I think the million-dollar question is, why have we been so successful this year? And I think there's a lot of concern about the risk of co-circulation of both influenza and COVID-19. I think from an individual risk, one, you may not be able to prevent COVID-19. Of course, there's face masks and so forth, but you can prevent influenza. We do have a vaccine now. And, there is concern people, may not want to go to the doctor. They want to avoid seeking healthcare if they don't need it, going to the emergency room, and getting a flu vaccine may be one way to do that. And also, I think heeding concerns about not wanting to overwhelm the healthcare system, as we saw in April in New York City at the peak of the coronavirus pandemic. But, every year, hospitals are also flooded with flu cases. And so really trying to make sure that we don't overwhelm the healthcare system so that we can care for patients who do have COVID. We've also done increased media and promotion. And because of the pandemic, this has actually brought really a lot more resources than we would have had in the past to promote flu vaccine. And not only on the media and promotion, but also with community engagement. The health department is really done a phenomenal job in terms of engaging communities where that have been hardest hit by the pandemic, as well as where we're seeing increase in cases, and promoting testing, for example. And so we've integrated flu vaccine messages into these other activities that are happening. I think the other exciting thing that has helped with flu vaccination is that this has also brought opportunities for new initiatives, which we haven't done in the past. And so one of them is with urgent cares, where we can ensure that people who don't have insurance have a place to go and get a free flu vaccine. We've been doing a lot more community vaccination events, either ourselves with community vaccinators or supporting other community-based organizations and linking them up with other vaccinators. And I think something else that's been good is this year we've had access to additional supplemental flu vaccine, some of it through CDC and some of it which the health department had purchased. But it's really enabled us to support a number of these community events and healthcare partners with extra vaccine, either because they had delays in receiving their own vaccine or they ran out of vaccine. And so I think this vaccine distribution has also been quite important. Next. So now turn to what are our lessons for rolling out a COVID-19 vaccination program. And again, some of this echoes what's been said by the other speakers, but just cannot underestimate the importance of engagement with communities impacted by COVID, with communities who will be recommending for vaccination. And just community-based organizations are going to be critical in our efforts, as well as working with trusted voices. I think an ongoing presence in the community is going to be important. And again, echoing what was said, it's going to be really critical for us to talk about what we know, what we don't know, how decisions were made, why is this group getting vaccine first, and so forth. And that we need to do some targeted outreach for communities that are prioritized for vaccination. Again, we've been doing this with flu because we do have coverage and uptake data. We know where uptake has been less than in other neighborhoods and have been able to specifically implement activities in those areas. There are a number of new partnerships which have developed in the course of the pandemic response, and these will also be important to our work. And then also ensuring increased access to convenient vaccination services. This was also mentioned before. I think it's just been essential for flu vaccination. We do have a flu locator on the health department website. We have over 900 sites listed. And so we have to make sure that people who are uninsured know that they have a place to go. But I also think to the extent that we can bring vaccine as close to the community we want to vaccinate, that will certainly help improve uptake. And next, this is my last slide before discussion. I just wanted to put a thank you out because much of the data that I've shown has been put together for me by amazing and talented, dedicated staff at the Bureau of Immunization and Health Department. And for people who are interested in more information about the measles outbreak, I provided the reference here. And that's the end of my talk. Thank you very much for the opportunity.
Thank you, Jane, for this, all this information about the really important work that the Bureau of Immunization is doing. I don't know if you were looking at the chat, but you had a chorus of support on the sidelines, underlining some of the things you've said. We have half an hour for Q&A, and the list is long. And so let me quickly start. I'm going to read the questions, by the order in which they have been upvoted. Some of them are directed to, specific participants, but other panelists should feel free to also jump in. The first question is from Andy Lakoff of USC. Dr. Colgrove showed an image of Andrew Wakefield posing for a photo with Donald Trump. In an era of intense political polarizations, it seems possible that the vaccine will become politicized and that a very significant portion of the US population, beyond the communities that are typically the focus of education efforts, may distrust a major government program of mass vaccination. Thus, one's political allegiance may shape what news one looks to and whether one trusts public health pronouncements. How can public health officials deal with the way that political identity may shape levels of trust in a vaccine? Anybody can jump in. I think maybe Rupali, I think that was definitely a question that you were discussing.
Sure, yes, let's start with an easy one, right? So, so it's really interesting because there's an article that's actually going to come out today with several of us colleagues where we are concerned about the politicization of the vaccine and how it has sort of undermined the process with regards to the current administration in office. I think with regards to what's the solution, right? What can we do in terms of moving forward? I think one piece that is going to continue to be very important is being transparent. And I was looking at some of the other questions here. I think the potential candidates that are in phase 3 trials are having additional scrutiny with regards to when there's one adverse event, right, that has been reported. All of a sudden now news media are reporting on it. That's not usually how that process works in the past, right? Mm-hmm. That's not usually, there's not that much interest. Yeah. And so I think continuing, and I think Dr. Cohn mentioned this as well, how do we continue to say that we've still gone through a process that is rigorous, that is still following the FDA guidelines, and that is still sort of being led by scientific integrity and has not been necessarily unduly influenced by political forces is going to be key here. I know that California, the state of California and New York are thinking about setting up some additional sort of advisory boards. So when the FDA and the CDC do come out with a recommendation, there's sort of a state level spokesperson that you can go to. And I think that's really key. I think we're getting more and more distrust with some of our federal officials. So I think thinking about who are those trusted spokespeople at these different levels within the community level as well as within the state level is going to be crucial.
Anybody else wants to jump in on this question? Maybe Amanda? No.
I just am trying to figure out why I'm not a trusted federal official.
Yeah. Well, it sounded, Rupali was emphasizing transparency, but transparency could have, other effects to it. When you're very transparent, people can also see the difficulties, the disagreements, the lack of consensus, perhaps among the experts. Okay. The second question is specifically for Amanda from Janae Park. What are your thoughts on how to balance, it's indeed about this, how to balance transparency about the vaccine development process and potentially confusing the public? Among people in my life, including those in the healthcare field, confidence in the COVID vaccine decreased as they heard about the complications and the setbacks with vaccine trials in the news. Okay, we are exactly on topic.
Perfect segue. So the hardest message to transmit is that when clinical trials are halted for review by FDA because there was an adverse event, that means the system is working. They are doing what they're supposed to be doing to make sure that all of the trial participants are being kept safe. It doesn't even mean necessarily that the individual who had the adverse event was vaccinated with the product, but we try to use these opportunities to reinforce that the system is working. I know that to non-medical people and non-scientists, that can be people who don't understand public health, that can be an incredibly hard message. I do think that being as transparent as possible in the end will get us there. If we need to talk about what we know and what we don't know, for example, we will know that the effectiveness of these vaccines a short time after vaccination, but we won't know how, as Jennifer said, we won't know how long these vaccines will protect you for 3 months or 6 months down the line. And so we have to accept some risk, but we also have to communicate the benefits, the potential benefits. And so I think that it is incredibly challenging, but being transparent will be better in the end. And even if it means telling people that we did see a signal, here's what we're doing to evaluate the signal, and here's how we'll shift recommendations if we do determine that there's some causality.
Anybody else would like to address the two sides of transparency?
Yeah, it's Jane. I guess I would just add that I think the guidance we give people when they're being vaccinated, in terms of what they can expect in terms of the local reactions and so forth, is just going to be really critical as well. I think if people get sick and they wonder why, and then they're like, it's the vaccine. But if we tell people, that this will happen, I think there'll be a better response. And I'll just give an example. There's Shingrix, which is a herpes zoster vaccine, which actually has more, pronounced local reactions than I've seen published with from the COVID vaccine trials. And there's really been unprecedented demand for that vaccine. That is part of when you're vaccinating someone, you sort of give them information and this guidance that this may happen and what to do about it. So I think there is precedent that the side effects alone, like on the transparency, like letting people know what to expect, will not be, I think, where the rate limiting step is for vaccination.
Mm-hmm. Okay. The next question, I think, is an urgent and skeptical one by Stephen Ho. One, how fast do you think the Pfizer vaccine will roll out? And two, do you think we should wait for 6 months before we get vaccinated, given that the 1976 swine flu vaccine caused rare Guillain-Barré disease only came to light after 25% of the population had been administered? Tough one. I think, Amanda, I think this is for you.
I can certainly start with the first one. I do think the Pfizer vaccine, and potentially even another one, the Moderna vaccine, announced that they've accrued enough cases to evaluate their data as well. I do think it's possible that both of those vaccines have authorization for use under an emergency use authorization by the end of the year, and that there will be in the millions or a couple 10 to 30 million doses available and being put into use over, as we go into January. I think that the vaccines will be more widely available to the broad population, more like in the spring, late spring. So I do think that these vaccines will have rolled out incredibly quickly, and we will have safety data from 30,000 individuals from each of these trials. I think 42,000 for Pfizer, which is really quite incredible. What I would say in response to the 1976 vaccine is that this is why we have all of these systems in place. We are in such a better place to detect adverse events than we were in 1976. And with our VSD system, with the Vaccine Safety Data Link that was mentioned, we can do something called rapid cycle analysis, and we can actually detect, as we have done with Shingrix, we have detected that there is a slight risk for GBS with Shingrix, and we have talked about this. It is ever so slight, but it just demonstrates that we really are able to detect risk with our vaccine safety data link incredibly quickly using the tools that we have today that really did not exist in 1976. So I would certainly get vaccinated with a vaccine that VRBPAC and ACIP approved and or authorized and recommended.
One thing I would add, Gail, if that's okay, is that, I agree that our data systems are much better, but I think one of the things that I heard often in talking to parents who reject vaccines is that there's this concern about what's natural and what's unnatural. And one of the complicating factors, and I think this is one of the disconnects between vaccine scientists and the public, is that there are more vaccines on the schedule. And what I heard over and over again is that the process of manufacturing has become much, much better, right? There's technology to isolate proteins in a way that didn't exist 30 years ago. And there are fewer, unwanted proteins in a vaccine today than there was in a polio vaccine in the 1950s, right? And that should be reassuring. And that's not reassuring to families because at some core level, it feels it's not intuitive that more science is better for you or more technology is better for you. I think one of the things then thinking about, maybe this circles back to transparency, is that the two vaccines we're talking about, the Pfizer vaccine and the Moderna vaccine, which have the fastest data, are both a vaccine technology that has never been used on humans before. And that's going to create a totally different kind of challenge for messaging because this is not a vaccine that sounds intuitively true. It's not a vaccine anyone got in childhood. And it could be great news because we all know that we've needed some updated technology for vaccine manufacturing for things like influenza for a long time. But it doesn't mean the public's going to be really excited. And you'll already see if you have, as little concern about your mental health as I do, where you do these deep dives into social media pages of people who hate vaccines, is that you'll already see conversations saying things like, my DNA is fine the way it is. And that's a misunderstanding of the technology, but also speaks to an intuitive sense of it's going to track on to anti-GMO rhetoric. It's going to track on to concerns about chemicals in the environment. And that's going to be a different kind of challenge. And because these are the two vaccines that thus far have more data because of where they are in the clinical trial process, that's going to create a really different kind of challenge for shaping the conversation moving forward, I think.
Mm-hmm. Okay, the next question, I think, takes us to a very important aspect of this whole discussion, and it is directed to Jennifer, but I think everybody should probably try to jump in on this. This is from Danielle Thompson. She asks, what strategies do public health professionals and educators have to get folks to think about health more collectively in our fairly individualistic society?
This is a really, I think, a question at the heart of where we are with public health right now. I think it's the heart of mask wearing controversies, right? It brings us to right where we are, which is how much can we ask people to sacrifice for the good of other people? And it's perhaps like one of the core questions in, I don't know, sociology and political philosophy, right? And public health. When I interviewed pediatricians about what they do in their practice, they uniformly told me that the argument that this was a mechanism to protect other people was largely unpersuasive to parents. And that was a loser's game for trying to use that logic. Having said that, when I talked to parents one-on-one, they mostly thought of themselves as really good people. And they identified ways that they worry about the environment, or they participate in recycling, or they're charitable in their community. And they saw ways they saw themselves as generous. And so it wasn't an all or nothing, like it's always about me or it's never right about the community, but rather it's contextual. What's challenging is that what we know is that the best predictor of who doesn't vaccinate their children is the number of people you know who also don't vaccinate their children, right? That these conversations cluster, and people tend to be generous to the people they know. They tend to trust the people they know. I think there's a separate conversation for a different day about how they mistakenly believe that you can't get infectious disease from people you know and like, which is a different problem. But there's ways that you can see that kind of community generosity or the willingness to do vaccination if it's about somebody they know, right? And so I think this vaccine is going to be really interesting because although the mortality data show that there's definitely an age gradient on who is the most detrimentally affected, what we know is it's not a perfect predictor. And we also know that this is not just a survive or not survive kind of disease, right? We have pretty good signals that things that are being called long COVID are going to create much more serious challenges to public health systems for possibly decades. And that might change people's calculus, both about what it means to protect yourself, but what it means to expose others in your network. And that, I think, is an opportunity to think through this. Now, when it comes to things like mask wearing, that's a low-level technology. It's not invasive, it's not biological, and so it doesn't cost you very much to participate. Vaccines are really different because what the risks are really different. And what we introduce when we introduce risk, it's a really different kind of conversations, particularly as we push into children's bodies. And so those are going to be really important conversations to have, but I'm slightly optimistic that there might be places with this disease, because we've been having this conversation for 8 months or so now, about what we can sacrifice to protect the people at the grocery store or the seniors, you know, or in our community. Maybe there's an opening for this to, I think, be more pronounced.
James, in your talk, there was an arc indeed that led from a more public collective framing, as in the polio case, to a more individualist one. There's other lessons.
Yeah, not necessarily. I mean, I think we have a deeply individualistic civic culture, and I think, you know, to the questioner's question, I think it's probably easier to change people's perception of their own risk than it is to change their perception of the society around them. I mean, just to echo what Professor Reich said, arguments appealing to civic duty are a complete non-starter, and you know, this is a challenge that extends across public health. You know, there was a paper many years ago arguing that public health really speaks a second language. The language of communitarianism is not America's first language. The language of individualism is. And I think that's been true historically. I don't think that's a new phenomenon. If anything, I think it's you know, it's always been with us.
Polly?
Yeah, no, I mean, I think I would sort of agree with what other folks have said. I think we're sort of seeing also as I think, as Dr. Reich mentioned, you know, mask wearing is sort of this very low level technology, and yet we have people that are marching to capitals and right, sort of saying it's my right to not wear a mask, it's my body. And so, you know, this is going to be such an interesting way forward as we start to see a vaccine that's available to the public, only because, and I can sort of relate this, I think, more to generalized epidemics related to HIV and AIDS, people know someone, right? I think that is going to be also different here. I think almost every person now, at least here in the US, unfortunately, has been exposed to this, a close friend, a family member, something like that. And so I think having that personalization and speaking about that this isn't something that is this unknown entity, you know, it's sort of moving into our lives in all of these different ways. But I think also thinking about, you know, if we can do this, if we can get enough individuals vaccinated, we can go back to quote unquote normal life, might be sort of another argument to consider in this case, because I think that's what people are also really seeking at this point. They're tired of being kind of isolated. As someone mentioned, we're about to hit this dark winter. So I think, you know, kind of framing it in this little different lens, like this is how we can get back to normal. If we can really focus on this, might be just, you know, another thought to consider.
Okay. The next question is by Musa Al-Garbi, and it is along the same lines. I will read the question. I think at least at the end of it, there is perhaps also a somewhat different direction where an answer could go. Musa asks, you mentioned that a lot of the discussion around issues like vaccination focused on parental choices, lifestyle needs provided some ways that people could more effectively message people about COVID-19 along those lines. Another potential approach may be to resist this kind of framing, to emphasize the communal aspect of vaccination, to play to a sense of mutual responsibility, duty, etc. Do you think this is a non-starter? I think this term was used here already. Is there a risk in following the path of least resistance, the individualistic framing, not just with respect to this particular vaccine, but for other public health interventions as well? So are there spillover effects when you are framing vaccines in individual terms?
So it's Jane. I'm going to jump in and
Sure.
sort of bridge both questions. I mean, I don't disagree with anything that's been said, but just in a different vein, what has come through from focus groups we've done, for example, around flu vaccination, it may not be people want to get a flu vaccine for their community or to contribute to some sense of herd immunity. But what is a motivating factor is that, and we see this with COVID, is people themselves don't want to get sick because they don't want to bring flu, influenza when they visit their grandmother, or they don't want to get, their siblings' newborn child sick. And that, that has come through, I think, consistently in work that the health department has done. We've also heard it for vaccines for pregnant women, that women are maybe skeptical. Why should I take a vaccine while I'm pregnant? They want to avoid medication. But when you explain about being able to protect their newborn before they can get their own vaccine, that also is a very sort of comes through as something that would motivate them, to get vaccinated. And we've also done some work, some surveys already looking at attitudes of New Yorkers. And I'll just say that, again, the idea about ending the pandemic and also about wanting to protect their family members have come through as potential reasons why people would want to receive a COVID vaccine.
I can add, in my neighborhood, there is a sign that tells you, a street sign that tells you that a deaf child lives nearby, and so you should lower your speed, drive carefully, and look. Signage like that, especially about people who are older and therefore more at risk, could be maybe some response to what Musa was suggesting. The next question.
Odell, can I just add? One of the things I think that's really challenging is that I think this is an easier sell if there's a perception that everyone is equally sacrificing. And right now, I feel like Colorado is entering its dark winter sooner. We've lost control of our numbers pretty quickly here with very limited testing capacity. And so it's really easy to feel the tension that some people are playing their part and staying home and other people aren't. And it's hard after this many months to not begin to feel resentful, right? That there's not equal sacrifice. And I keep thinking historically, like, didn't we used to have like sugar vouchers and you couldn't get extra stuff during during a world war, and weren't there places of sacrifice and no one even had Netflix back then? Couldn't we imagine that we've had a history of everyone mutually sacrificing? And I think one of our biggest challenges right now with the inequality we have is that we have this sense of scarce resources and competition for scarce resources. And that changes the calculus too about what are you sacrificing if you don't perceive everyone else as taking an equal role in that.
The next question is from Brian Hagen. Dr. Reich, to you, Jennifer. You mentioned the complicated optics of the military's role in the distribution of the COVID vaccine. Can you talk more about that? On the one hand, it's hard to think of an institution much more associated with coercion than the military. On the other hand, public opinion polling shows that in the US, the military is one of the few remaining institutions that retains high level of public trust. It's the most trusted institution.
That was a very good summary of the complicated optics of the military's involvement. And I hope Amanda will weigh in too about some of the logistical challenges, right? And that the way the military has been identified in terms of their skill set around logistics, but also it's an unusual role in public health domestically. And I agree, like the government rolling out vaccines, although Amanda is a very trusted government employee, even the last several years, I think we've heard increasingly condemning rhetoric about governmental expertise. about depth of experience being a negative. And the military is a pretty deeply entrenched institution. And so for them to be rolling this out and making the distribution decisions federally, and we actually have no role for the federal government historically, right? Most vaccine things are handled at the state level. This is a really new, very visibly heavily handed way. It may be pragmatically the right choice. I think there's conversations to have about that. But I think how it's going to affect perceptions, I think has to be managed pretty carefully.
Thanks. I'll just add, I am hopeful that when this vaccine is actually rolled out, it won't actually look any different than H1N1 looked or any other vaccine program. The role of the military, as Jennifer said, is focused on logistics. It is going through the states. The states will be ordering vaccine and it will end up in providers' offices. There's certainly a heavier federal hand, but not, it won't be, I can't say quite yet because it's not totally clear what will happen, but at least at this point, I think that the idea that you can trust the military, I think the optics, it has been decided that the optics may be better because the military's got this and they can manage the logistics, unlike other programs. But in the end, I think that some of those optics will go away once vaccine is distributed and it'll start to just look like any other program. There are a lot of questions about equity and allocations and things like that. And I think those are the complicated questions that the military really won't have any decision-making authority in. That doesn't mean, it's still not, it doesn't mean that HHS won't have, but, our hope is that the independent advisory groups do make recommendations that are followed by the US government.
Okay, the next question is from Rogers Brubaker from UCLA. James Colgrove noted that questions about vaccine mandates may arise not only in connection with governments, but also, for example, in connection with private colleges, who might require students to be vaccinated. Jennifer Reich also raised this issue. I'm curious about the legal foundation for possible vaccine mandates, with more or less narrowly drawn exceptions on the part of colleges, employers, and other organizations. Would the legal basis for mandating vaccines differ for private and public colleges and universities, or for private sector or public sector employers? For what it's worth, UCLA is requiring flu vaccines this year for all people on campus.
I mean, the legal basis might vary. I think the result would probably be the same. In general, courts have been fairly deferential to public health regulations, presuming that there is a scientific justification that they aren't being applied in a way that's arbitrary or capricious, and that there's a rational purpose to the law. And to take the example of private colleges and universities, there's all sorts of regulations related to health that these institutions enforce. Certainly with respect to public sector mandates, there's a long history of laws supporting that. And I would not have too many questions about that. I would actually be more concerned about the political ramifications than the legal ramifications. I think that mandates really raise the potential for backlash and for undermining public trust. And I think that's a somewhat greater risk than a court challenge. I think we have an example of this actually from about 15 years ago when the HPV vaccine was licensed and many states moved quite quickly to try to mandate it as a condition for middle school attendance. And the effort really blew up in the faces of those states because for a variety of reasons specific to that vaccine. But I think the political concerns around mandates are as significant as the legal concerns.
Sad about the private sector. We can see from the protest signs that Americans don't have a great grasp on average of the difference between public and private sectors. People talk about their First Amendment rights at Walmart, right? Like these are disconnects about what the law means. And that's because most of our public life has become privatized. And so the blending between the public and the private is challenging around this. Corporations are not great public health institutions, and they're not really set up to do that. But we could imagine that these kinds of employment-based mandates would be legal. given both the expanding role of corporations and, from Hobby Lobby downward, right? We can think about the expanding role of corporate individualism, if that's a term, but also that it would be consistent with their goals in the workforce. So could you imagine a grocery store chain requiring immunization as a condition of work? That would affect their health insurance, their absenteeism, and they could advertise to consumers that their workforce is immunized. And we know about 20% of grocery store workers have become infected. So we know this is a significant risk. Whether or not that's the right place for intervention, though, I think is a much bigger question, because again, corporations are not equitable institutions. They are not, they don't have great sense of privacy, and they're just not equipped for this. And yet I think that most cynically, that'd be a place. The other thing I would add is over the summer in the Mountain West, we saw a huge number of states passing mostly GOP platforms at the county levels across a bunch of different states, calling for, like, as part of the Republican platform, which they didn't make a platform this year, but calling for them to include things like lack of biological discrimination. And they were using terms around like what this would mean to have basically as a condition that you should not be able to, we should have laws against employment discrimination based on vaccination, based on genetics, based on biological characteristics. And they didn't go anywhere in actionableness, but I think they signal increasing concerns about like what this might look like going forward. And that was over the summer before we had serious vaccine candidates.
Anybody else wanted to address this question?
I mean, I would also just add that we do have some experience with this with flu vaccine mandates for healthcare workers, which have been the subject of some successful challenges related to employment, changing of employment contract conditions, more of a procedural objection than a public health objection. But, you know, I mean, the resistance to flu vaccine mandates among healthcare workers, I think, is of concern and telling, and perhaps gives us cause for concern about a mandate for a COVID vaccine.
Yeah. Okay, we have reached. We went over our time a little bit. I apologize to the 4 people whose questions are still up there on the Q&A. Some of them have been there for a long time and we didn't get a chance to answer them. Many thanks to all of our panelists, to Amanda, Rupali, Jennifer, Jane, and James. This was a fascinating panel. I think we learned an enormous amount, but unfortunately not enough. There are still 4 more questions. I think there are many more questions in people's heads as they are still digesting everything that happened here. So unfortunately, we can only say that we can go ahead and continue the conversation in some other means. And thank you again for joining us today.
Thank you so much. It was great to be here.
Sure. Thank you. I'm going to just linger here, you know, as our crowd sort of flocks out through the exits. Yeah. But yeah, this was a great panel, I thought. You know, really, a lot of the presentations engaged with one another. The questions raised, you know, the issues that are really at the core. There was very little that was left of field. And when you're dealing with vaccination, not to have, you know, out of, you know, left of field questions, this is really, I think, an accomplishment. Jane, you still with us? Yes,
I am. So thank you for the opportunity. It was really a great panel, and I think a great discussion, which we really only just scratched the surface of. I'm sure we could have gone on for much longer. So I look forward to continuing the dialogue. I'm going to hop off. I actually have now a 2 o'clock meeting to get on. So thank you, and everyone be well. Bye-bye.
Thank you. Thanks for participating.
I'm in the same boat, but thank you so much. And it was great to hear from, of course, James and Jennifer and the other folks. It's always really nice to hear that other people are working in this space and are bringing these great perspectives. So thank you so much, Gil. Thank you.
So great to finally meet you, Rupali.
Thanks for so much for bringing us together, Gil. It was great.